In this chapter, we are also going to review lithium and its use in bipolar disease. As a matter of fact, you see the first statement here. Lithium remains the drug of choice for bipolar disorder. Does it mean it's the only drug used in bipolar disease? Not at all. Antidepressants are required for the depressed phase of bipolar disease, and often antipsychotic, major tranquilizers are required during the manic phase of the disorder. Mechanisms-wise, we know what lithium does at the molecular level. Look, it prevents the recycling of inositol, decreasing the levels of PIP2, meaning down the road it can decrease IP3, decrease diacylglycerol, and therefore interact with any receptors that you know of that are GQ coupled. At the same time, lithium is well established to lower levels of cyclic AMP. As such now, any GS, GI coupled receptors would be interfered upon with decreased GS and magnification of a GI type of effect. When you look at this, between you and I, it would seem like all of pharmacology would be affected by a drug like lithium, and you're not that far off. Therefore, even though we have one slide here covering lithium, you could have put an entire book about lithium and its potential side effect. So beware of it on your exam, because there are so many theoretical links you can put with lithium. Here are some of the main ones we know have been on the exam. Number one, needless to say, the drug has a narrow therapeutic index. With such a pharmacology, it will require therapeutic monitoring because of potentially life-threatening side effect. The first type of side effect we should know of is that lithium is very similar to sodium, both in size and in charge. As such, you can expect lithium to get into cells and depolarize these cells. As a CNS drug, that depolarization could result in life-threatening seizures. This is one of the primary reasons that makes the drug required to be monitored in the patient. Drug levels must be maintained within a very narrow range. But what your boards have often loved of lithium is to link the story of cyclic AMP or IP3 diacylglycerol with other receptors. And they've emphasized a lot the potential for endocrine to be affected by lithium. Look, lithium patient may develop hypothyroidism, and that hypothyroidism is classically because of the fact that TSH binds to receptors, and these receptors are GS coupled. Because lithium decreases cyclic AMP, it prevents the effect of TSH. If this is not enough, your note also indicates that lithium is a peripheral deiodinase inhibitor, so it also prevents the conversion of T4 to T3. Well, with this in mind, hypothyroidism, by the way, would certainly not benefit a patient who suffers from depressed mood, being that hypothyroidic patients have depression from the lack of thyroid hormones. Another major story is the idea of nephrogenic diabetes insipidus. This is again because ADH receptors this time are GS coupled. Now this is not all ADH receptors, we're talking the ones in the kidney, because ADH also has receptors that are GQ coupled in the vasculature. Those are also interfered upon, by the way, but would have nothing to do with NDI, but rather to do with oppressive effect, with the actual vasoconstrictive effect of ADH. So as I'm looking at that story with NDI, nephrogenic diabetes insipidus, the idea would be, if a patient suffers side effects from lithium, what should I do? Treat the side effects or remove the drug? You know, when it's presented bluntly like this, the idea is let's remove the drug, or at the very least, let's decrease the concentration of the drugs in the patient's body. Because really it's never too good to let side effects happen from a drug and then further treat the side effect by using other medication. By the end we would end up with a walking pharmacy with all kind of drug interaction. So how am I going to get rid of lithium? Well, let's think again that lithium looks like sodium. And let's take a little white page together. Look, here is your kidney tubule. You recognize this is not a telephone, it's your glomerulus, your nephron, and very classically we know that ADH is normally working in the collecting duct, trying to cause reabsorption of free water, of course in that process allowing the concentration of urine by the patient. This ADH receptor is not working because of lithium. Lithium is blocking the function of a receptor by decreasing cyclic AMP. To increase lithium clearance, well, to increase lithium clearance, because it is like sodium, we're going to think use a diuretic. It's a great idea. But now if I'm going to use a diuretic, I need to choose accordingly. Remind me from your diuretic chapter, if I block sodium absorption proximally, in the loop, or distally, what tends to happen because of the hypovolemia to aldosterone level? Yeah, you remember well. It will increase aldosterone levels. And as it increases aldosterone level, it's going to force retention of sodium to the expense of potassium and protons. We should all remember this well. Well, then what do you think this would do to lithium, which is like sodium? Lithium would follow together with sodium and be retained. If that's the case, do you think using a diuretic such as a thiazide would help in the nephrogenic diabetes insipidus to lithium? Here's the trick. Although it's a good treatment for the disease, nephrogenic diabetes insipidus, it would actually quite likely decrease lithium clearance by forcing its reabsorption through the sodium, potassium, antiport that aldosterone controls. So rather, when you want to increase lithium clearance, what you want to use are drugs that block this segment of the nephron. You want to use drugs like amiloride, like triamterene, to make sure that then this lithium, together with a little bit of sodium, have to be excreted. Indeed, downstream from this pump, there is nothing left for sodium and lithium to be retained, so it has to increase the clearance. Also, it will never worsen or exacerbate too much the water loss associated with nephrogenic diabetes insipidus, because amiloride, triamterene, these are drugs that are very, very weak in the diuresis, but plenty enough to increase lithium clearance adequately. Contrast when a board question asks me about chronic thiazides or chronic loop management and what they do to lithium clearance. Well, this was a statement that was written in your diuretic section. Chronic loops, chronic thiazides are bound to actually decrease lithium clearance, and they decrease lithium clearance through the mechanism we explained on this diagram. So now you've established this, you should be fine for that type of board question. Now comes the issue of teratogenicity for this medication. As I'm looking at the teratogenicity of the drug, there is one big classic teratogenicity mentioned, Epstein's anomaly. Epstein's anomaly, if you want, I'm going to try and draw that too for you. It's going to be complicated generally. Imagine that this is your heart. It looks exactly like this. This is your right atrium, right ventricle, left atrium, left ventricle. Well, no doubt that normally right here you should have what valves? Yeah, of course, you should have your tricuspid valves. And those tricuspid valves right here, in Epstein's anomaly, they're actually downward into the right ventricle. Not only they're downward into the right ventricle, but they also tend to be stuck along the wall, adhering to the actual posterior wall of the right ventricle. And as they're downward, now here's what's going to happen. You're going to have a smaller right ventricle. You know, it means small right ventricle, and it means regurgitation. With a small right ventricle, less blood is going to the actual lungs, so there's going to be some issues with hypoxemia, and more blood is going to regurgitate into the right atria, so it'll increase the size of the right atrium. With this will come the potential for arrhythmias, of course, and an issue that we refer to as Epstein's anomaly. If it's associated with lithium and it's a significant congenital heart disease, well, the idea would be never leave a lady who's pregnant on lithium so that the baby does not develop that downward displacement of tricuspid valve with a small right ventricle and enlarged right atria and all the consequences. What would we then use during pregnancy? Well, during pregnancy, what we're going to use are particularly the drug gabapentin. To avoid Epstein's anomaly, we must not administer lithium during pregnancy. So what would we do if a pregnant lady had bipolar disease? Well, classically, the drug gabapentin, an anticonvulsant, and also the drug clonazepam, a benzodiazepine, have been used during bipolar disorder management in pregnant lady. Now, amongst other drugs that are used in bipolar disease, valproic acid and carbamazepine are also approved, particularly during the manic phase of the actual disease. Of course, would you choose valproate and carbamazepine if you were pregnant? Well, you know that the answer to this is absolutely not. Just like lithium, they are teratogenic. Let's not forget that valproic acid is associated with spina bifida, and carbamazepine is associated with both spina bifida and cleft lip and cleft palate. So gabapentin and clonazepam, please add them to the notes. I think they fell off the book.